There we go. All right. So I think we're ready to start our next session. We are again doing poster presentations for the celebration of scholarship for the graduate nursing students. We've done podium presentations last week, and we're finishing up our posters today. And so our next speaker is Anna Caringella. Close, not too close. Anyway, she's doing management of anesthesia-induced anaphylaxis, a quality improvement project. So Anna, I'm going to let you take over.
Okay. Okay. So good afternoon, everyone. My name is Anna Caringella, and the title of my DNP project is Management of Anesthesia-Induced Anaphylaxis, a Quality Improvement Project. My project looked at the implementation of cognitive aid to help anesthesia providers treat the rare occurring event anaphylaxis in the OR. A simulation technique was used to deliver a scenario of a patient undergoing anaphylaxis so the providers could determine if the presence of the cognitive aid better assisted them in treating a situation they don't encounter often. A little bit of background. The estimated incidence of anaphylaxis is 1 in 4,000 to 1 in 25,000 cases, and 1 in 10,000 to 1 in 20,000 cases, with a mortality of 3% to 10%. Due to the rarity of anaphylactic events, treatment modalities may be missed by anesthesia providers related to their lack of experience with the rare event. Anaphylaxis causes morbidity and mortality if anesthesia providers are unable to manage anaphylaxis quickly and correctly. Cognitive aids have been shown to prevent incorrect management of infrequent situations. Access to treatment guidelines included on the cognitive aid have been found to improve timeliness of treatment. Accurate treatment of anaphylaxis can improve patient outcomes, decrease death from anaphylactic events, and decrease hospital costs. The purpose of this quality improvement project is to evaluate the use of a cognitive aid to guide treatment of anaphylaxis in the OR while under anesthesia. If it works, then it will be implemented in the OR. Approval from IRB was obtained prior to implementation from Millikan University and the hospital where the project was implemented. 2 frameworks were used to guide this study. One was the Iowa model and one was a simulation theory. The revised Iowa model was adopted to guide the implementation of a cognitive aid in the OR to manage anaphylactic occurrences. The subsequent steps of the Iowa model guided facilitation and implementation of evidence-based practice of this quality improvement project. The first step is to identify a triggering issue. A problem was identified in a private regional hospital in central Illinois as lacking ancillary tools to assist providers in situations that occur rarely and quickly and that can be life-threatening for patients. The next step is to select a purpose question, which was stated above, and then to form a team. This team included the project leader, which was myself, the project chair, the clinical expert, who is also the director of the School of Anesthesia, and the assistant clinical anesthesia director of staff at the hospital, who helped ensure that all anesthesia providers were informed of the training project and the details of the study. Next is to assemble, appraise, and synthesize a body of evidence. An extensive review of literature was conducted prior to implementation. Research was broken down into specific categories, including anaphylaxis, which looked at occurrence in anesthesia and recognition and treatment, crisis resource management, which looked at simulation training in anesthesia, and then impact on patient safety, and then cognitive aids. The last 2 steps are to design and pilot the practice change and to integrate and sustain change, which would ultimately result in placement of the cognitive aid for anaphylaxis on the anesthesia machine for providers to have access to at all times, and an annual simulation training involving anaphylaxis and the use of the aid for providers to practice this rare event. Incorporation of this training also reminds the anesthesia providers that the aid is available to them and where they can access it if needed. Simulation theory. The common design for simulation theory is you use a simulation training with the pre-education session followed by a simulation scenario. Once the simulation is finished and the data is collected, a debriefing session is held for participants to have the opportunity to reflect on their learning and review their performance. This was completed, giving the anesthesia staff time to reflect on how the simulation went and discuss their actions with and without the presence of the cognitive aid. Simulation can be portrayed in many different ways, including something as simple as role play to the use of high fidelity and virtual reality simulators. All methods have been proven to be effective. This simulation was delivered in a simple OR setting without the use of high fidelity equipment. The methodology of this project was a pre-test, post-test evaluation of the use of a cognitive aid in a simulated setting. The setting was the operating room of a private regional hospital in central Illinois. 8 certified registered nurse anesthetists were the participants. Interventions included the participants were read a clinical scenario on anaphylaxis. They were given 2 minutes. Each group was given 2 minutes to work together to simulate treatment of anaphylaxis from memory. Following that, 2 more minutes were given to the same team to simulate treatment of anaphylaxis, but with addition of the cognitive aid. A checklist was used to mark off recognized treatment modalities per evidence-based guidelines, and pre-aid and post-aid checklists were the same. Debriefing was held following end of simulation, where a discussion of how the simulation went in regards to treatment of anaphylaxis with and without the cognitive aid. Surveys were anonymously completed by participants for data collection and interpreted by the project leader. Below on the poster, you can see an exact copy of the cognitive aid that was used to assist the providers. The cognitive aid was constructed by a team from Stanford Medicine and is available to the public for download for free. This aid, along with other evidence-based guidelines that were researched, were used to create the checklist that was used to evaluate the steps the anesthesia providers called out during both of their treatment rounds. I know you can't really see the aid that well, but I'll just kind of go over it a little bit. The first page of the aid lists some symptoms to look for that a patient might be experiencing, including hypoxemia, hypotension, tachycardia, bronchospasm. It lists a few basic things that you would want to do really in any crisis situation, like calling out for help, calling for a code car, informing the team, and maybe telling the surgeon he needs to stop for a minute. And then it gives you basic stuff to do if the patient experiences like cardiac arrest or becomes pulseless. It also, what I think is really cool is it lists some other differential diagnosis at the bottom, so you can kind of think about what things might else be going on with your patient if treatment isn't working. The second page of the cognitive aid lists in steps the treatments that you should do for this patient having anaphylaxis. Just a couple of them. It tells you to discontinue the potential allergen, discontinue your volatile anesthetic, something like increasing your oxygen to 100% and starting fluid boluses, as well as giving epinephrine doses, and it even lists the doses and the amount of frequency that you should be giving them. It also lists other things that you might not be thinking about if you're in this type of situation, like considering getting additional IV access and applying more invasive monitors, things that as the anesthesia provider you can maybe delegate to other people in the room. And then at the bottom, it looks at post-test stuff that you can get, like serum tryptase levels, serum histamine levels, to maybe figure out what caused the reaction once the patient is stable. All important things that you might not think about if something happens so suddenly to your patient. Results of this study: 2 separate groups participated. Group 1 had 6 participants and Group 2 had 2 participants. A checklist was created with treatment modalities for anaphylaxis and consisted of 17 checkboxes. The pre-aid checklist for Group 1 received 10 check marks, meaning they could identify 10 treatment modalities without the aid. The post-aid checklist received 13 check marks, meaning they could identify 13 treatment modalities with the presence of the aid. They showed a 30% improvement with the use of their cognitive aid. For Group 2, pre-aid checklist, they received 6 check marks, meaning they could identify 6 treatment modalities without the cognitive aid. The post-aid checklist, they received 12 check marks, meaning they could identify 6 treatment modalities with the presence of the cognitive aid. Group 2 showed 100% improvement with the use of their cognitive aid. Below is a table comprised of the data that was filled out in the anonymous surveys following the simulation. The participants were asked questions, and then they could either rate with strongly agree 4, agree 3, disagree 2, and strongly disagree 1. All of the participants answered either strongly or agree to all of the questions. No participant selected that they disagree or strongly disagreed with anything. Some examples of the questions included: the overall experience during the anesthesia crisis management scenario was beneficial, which all 8 participants gave a strongly agree. Additional knowledge was gained during the anesthesia crisis management scenario. Only 2 people agreed, the rest of the participants strongly agreed. The events that took place during this scenario were realistic, which all of the 8 participants strongly agreed. I feel more confident in the treatment of anaphylaxis with the cognitive aid. All but 1 participant strongly agreed, and that other participant agreed. And then I would encourage colleagues to utilize a cognitive aid during the management of anaphylaxis. All 8 participants strongly agreed. The debriefing findings: participants responded that they felt the simulation went well, but that having the aid present during the second part improved their recall of necessary treatments. Participants felt their actions were improved based on the presence of the aid, and that it would be beneficial to have the aid present at all times in the event that anaphylaxis took place during their case. The common agreement was that the aid should be placed on the anesthesia machine so that it could be easily accessible and everyone would know where to locate it. 8 questions were asked during debriefing. Some examples included: how do you feel about the events that took place during the simulation? Do you feel the cognitive aid improved your actions and care of the patient in this scenario, and why? And do you feel it would be beneficial to have the cognitive aid to you in the OR if anaphylaxis should occur with your patient? Following data collection, it was recommended that the simulation be repeated annually with the cognitive aid to familiarize staff with the aid and where to locate it in the event of anaphylaxis in their patient. It also helps them to practice a rare occurring event they do not get to practice often. And then every study always has some limitations, and there were a few with this study. 16% of CRNAs showed up to participate in the voluntary study, which is unfortunately a very small sample size. Lack of attendance was due to availability due to a busy OR schedule. Only those that were not in a case for the day were able to come and participate. Lack of interest regarding the simulation topic, and difficulty engaging the anesthesia providers to participate in quality improvement project. Another limitation that I faced was the lack of high fidelity simulation equipment to deliver a lifelike scenario to participants due to costs and what was available to the project lead from the facility. Data collection in simulated environment was not on an actual patient, so the lack of evidence of improved patient condition with presence of the aid isn't really able to be presented, but it's also unethical to inflict anaphylaxis on someone for the purpose of this study. The aid may not be utilized once implemented based on provider preference or forgetting it's available to them if anaphylaxis should occur. In conclusion, rare and life-threatening events in anesthesia demand that providers process information quickly and act precisely to ensure positive outcomes for patients. In order to reduce mental workload during these usual chaotic times, cognitive aids have been developed to assist providers with making critical decisions instantaneously. Previous research shows that aids that are designed to deliver specific information will be used more by providers, showing improvement in outcomes for those specific situations. Though further research is necessary to demonstrate that providers properly utilize these tools in these rare events, having the cognitive aid implemented and readily available to all anesthesia staff provides a sense of comfort and reassurance if anaphylaxis should occur under general anesthesia. And then my references are listed below. And I just wanted to say thank you to Dr. Bentley and Dr. Flatley for being involved in helping me with this project. Thank you.
It really sounds like your project went very, very well. I have a question for you, though, and that is in regards to not, excuse me, your particular project, but about cognitive aids in general.
Mm-hmm.
Do you think there's a tipping point when we have too many cognitive aids in the drawer?
I definitely think that if you have too many things, then you do spend a lot, you might spend some time flipping around looking for which one might pertain to you. What I do think was really nice about what Stanford did is they have an actual booklet that you can get that has all of their cognitive aids in it, which I think would be another cool project for a different student to look at. But it really only highlights those rare events or the very, very serious ones. So they have like your basic ACLS algorithms at the beginning, you know, VTAC, VFib, asystole, those things. And then it has malignant hyperthermia, airway fires, anaphylaxis, just those few things that you don't see very often that you might want to reach for and get some help with. So I think definitely having too many things could kind of confuse the provider, because you got to fumble around with different papers. But if you know where to locate and you are trained on it and you know exactly what's in the aid, then I think it would eliminate some of that fumbling around.
And I really like that idea, you know, either a booklet or, you know, a ring of cognitive aids where it's all kept neat and where I can grab that one item and then flip to what I need, you know, maybe some kind of tabs or something on the outside so I can get to the one I need quickly. I'm always picturing, you know, when we talk about all these cognitive aids, you know, the drawer, I open the drawer and there's, you know, this plethora of cognitive aids in there while I'm trying to deal with an emergency. And can I find the one I really want, you know?
Totally. And I think another thing too is why this practicing every year would help is I think something that we might forget to do is we might be able to say, you know, we're the anesthesia provider, we're at the head of the bed. We could say, maybe the circulator nurse, can you locate the book and flip it to the page that says anaphylaxis, and kind of delegate that so they can help you. Because I think the important thing to take away is that anesthesia providers, you know, they remember the basic stuff. The patient's hypotensive and tachycardic, they know how to treat that, but it's those little things at the bottom of the aid that are kind of forgotten. So if you delegate that out, then somebody can kind of say, oh, did you remember to do this? Oh, did you remember to do that? And help you.
Other questions or comments?
Good job, Anna.
Anna did a great job. The poster looks fantastic.
Thanks, Nicole.
Nice job, Anna. Congratulations.
Thank you.
You're done
Anna.
with that part.
Oh,
Good job,
thank
Anna.
God.
Doesn't it feel
guys.
good?
It feels really good.
It's hard to believe you've been doing this now, what, working on this a year and a half. So it's good to get to this point, I think.
Yeah, didn't really seem like it was reachable.
All right. Well, then we offer you congratulations, and we will take a little break until 3 o'clock when Nicole will be up, okay?
Thanks, everyone.
Congratulations.
Bye, Anna.
Bye.